Good afternoon. I'm Dr. Sarah Smucker Barnwell, and I'm a member of the board of the American Insurance Trust, known to most of you simply as the Trust. I am pleased to once again be joined by my colleague, Dr. Margot Adams Larson, to present today's telehealth community chat. In the interest of time, we've placed our bio on a slide for you. I hope you enjoy and benefit from our telehealth chat today. Please join me in welcoming Dr. Margot Adams Larson.
Well, thank you so much, Sarah. It is such a pleasure to be here with you today and getting to chat more about all of these ever-changing topics. So as a reminder, we do these quarterly. It's always the best part of my month, the best part of my quarter, actually, to just review where things have been. And I was sharing a little ahead that a month ago when we were prepping for this and looking through some of the past questions and doing a little digging and research, things have changed again, even since then. And so we're constantly trying to keep up with things. But we're really focused on providing some practical how-to information from an ethical perspective. And so I think just realizing we take the questions, we try and find some information and some resources to share when we're having our chat, but ultimately we don't have a specific answer generally. We have answers about things to think about and ways to think about the circumstances or the situations or the questions that you have. And so that's our goal, is really to inspire you with some other ways and ideas of things to bring into those thoughts and conversations. And like Sarah said, we don't have an agenda slide. We're changing things up just a little. If you've been a fan and watching some of our other chats. Today, though, we're going to cover some fairly, I'll call them juicy topics, because I think they'll get a lot of questions rolling as well. We're going to talk about telehealth integrations and digital therapies. We're going to talk about when you're thinking through CDC requirements and state requirements and reopening to patients coming into your practice. We'll talk a bit about couples telehealth therapy. We'll talk about how to think about changes or pending changes in terms of insurance coverages. And then we have a couple other topics that we'll reserve to the end, but we have a new certificate to talk about and also just some interjurisdictional newsy items. So we'll kind of move through those. As Sarah mentioned, drop your questions for today into the Q&A. We'll be able to monitor those as we're chatting and try and include answers and or touch on those topics. So I guess without further ado, I'm going to roll it back to you, Sarah. I know you have been doing some work and some research and some reading in the areas of digital therapeutics, and this is up and coming. Probably 10 years ago when teletherapy was up and coming. It's kind of that. This is the frontier for digital therapeutics. And so we thought having a little time to kind of plant some seeds about it and how it integrates into telepractice would be a great way to kick off our conversation today.
Thanks, Margot. Well, as you know, we received a question since our last telehealth community chat that inquired about the distinction between distance therapy or online therapy or video conferencing therapy. These terms are often used synonymously, and digital therapeutics. And they said, well, is this the same thing, or what is this nomenclature? And so I thought it was a great opportunity to talk about this, because as you say, this burgeoning area is evolving quickly and is a really significant growth area in the practice of behavioral health, and particularly online behavioral health. So let's start with our operational definition. Digital therapeutics, this is the delivery of any medical intervention, inclusive of behavioral health intervention, directly to patients using evidence-based, clinically evaluated software to treat, to manage, or to prevent a broad spectrum of diseases and disorders. And this can be all manner of concerns. We see mobile applications that help us manage diabetes and the health behavior associated with that. We see stress reduction, mobile applications, software, wearable devices. I think we see a strong presence of these types of software, and often I'm talking about mobile applications. That seems to be the most popular arena right now in health behavior. So there's a huge growth industry in weight loss and fitness and chronic condition management. And I think what we're seeing increasingly, these apps have sort of come into their own. I think about 5 years ago, many of us may have used an app to augment our in-person or our video conferencing therapy. I know that for a long time, I've used apps like Breathe to Relax or PTSD Coach or PE Coach to be a nice companion. Oh, can I speak up? Yes, I can. Please let me know if you're having any trouble hearing me. I do tend to be soft-spoken. So these, I think historically, it sounds like we're having a little bit of audio trouble. Margot, can you hear me okay?
I am hearing you quite fine, Sarah. So it's coming through clear here, but maybe
Okay,
just leaning in a little.
I'll do my best. Historically, these have been an augment to our in-person care or our video conferencing based care. And they really, I think, did an excellent job in terms of being a companion. I think what we're seeing now is that increasingly these are being treated as standalone therapies. In fact, some of these, such as I think Pear Therapeutics is a good example, has sought FDA approval for opiate addiction treatment, medication assisted treatment, as well as ADHD treatments. So I believe that we are seeing kind of this interesting shift where these digital therapeutics, which we've always thought as kind of being complementary or, otherwise something that was not necessarily in the main of treatment, come into their own as being a type of treatment in and of themselves. So this is an increasing presence we see in the treatment of substance use disorder and serious mental illness that I think is, very, very compelling, and we should be paying attention because, there is an exciting opportunity for us to extend the way we give care. I think of, there are some mobile applications that work with wearable devices that my clients have. Things like, I'm not endorsing any particular brand. I'm just gonna say them aloud. Things such as Calm, things such as Headspace. These are mindfulness and relaxation apps. And some of them integrate with the wearable devices that my clients wear, such that it pings them to remind them, have you done your meditation today? It pings them to remind them, have you taken a walk? And these can integrate very nicely with the care plans that we collaboratively create. So I think there's this real opportunity for us to think about how can the care I give my patient integrate with some of these modalities. I think that I would be remiss not to say that there is a trend that is happening right now that some of these are being treated as standalone, wherein that they're indicating a clinician is not needed. Now, I think that's an empirical question, and they are collecting the data to opine on that. But I think it's an interesting question for all of us to think about, how much, automation is coming into the field, because increasingly, there is a tremendous push, I would say, of the telemedicine industry broadly to think about how they can reduce the necessary numbers of those clinical hours, because, we are expensive. There's only one of me. I don't scale that well. I just tend to be able to be one place at one time. And, I like it that way, not looking to be replicated. So I think that there is a push for replacing clinician time with the use of automation, with the use of bots, with the use of digital therapeutics. And I say this not to be doomsday or say that I even always think it's a bad thing. I joke that if I never hear myself do another progressive muscle relaxation, that might be okay. But I think that it is certainly something as ethicists, we need to put on our sort of ethicist cap and think about, where is that appropriate? Where is that not? Where do I endorse that in my own clinical practice? And where do I not believe that is in my patient's best interest? And it is a burgeoning sort of area of empirical question. So, as Margot said, I don't necessarily have an answer and say, this is the right amount of automation for us. But I do think it is something that we should be considered, well considered as we move forward and thinking about how we want to bring digital therapeutics in and where's the clinician's place and where we're okay augmenting with some of these tools that can help expand our reach and help to promote adherence to the treatment plans we collaboratively create with our patients.
Oh, Sarah, I think you really hit on some really key points. There's maybe even a leverage question of, what is it that it can help you with your patients and help your patients versus replacement of a clinician and clinical thinking and decision tools. And so it's going to be one of those things where as new technologies and new apps and new features come to be, I think we'll be finding these questions of, is this something that I need to do with my patient, or is it something that can actually help beyond even the office setting or the practice setting that could be of benefit to inform treatments and overall help both patients and the treatment process move along. So, I think really key. We did have a question come in to just repeat the definition of digital therapeutics. And I think I would love to hear it again, actually, because you had a nice operational definition, but it also now is helpful to kind of close out that conversation and move into our next topic. So I'll let you repeat that definition and then I will jump into the next thing.
I'm also, with this new snazzy configuration of Zoom, which Margot and I both love a lot, I put it in the Q&A box, but just, it's better to say it. So digital therapeutics, we're talking about the delivery of medical interventions that includes, psychological intervention, behavioral health information, intervention directly to patients using evidence-based, clinically evaluated software to treat, to manage, and to prevent a diverse spectrum of disease and disorders. So, that's a pretty inclusive, broad definition. But I think that they cast a wide net in hopes of capturing things like mobile applications, in hopes of capturing some of the wearable devices, in hopes of capturing internet psychoeducational content or interactive internet content. So I think that's all of that. I think, we could go a little farther on the fringe, not fringe, but I mean, they're interesting. They get very offended. And so this is not the right term. Gamified content. Some people really like it being called gamified. Some companies say, don't call us gamified. We're not.
But they engaged content.
The concept is that it is a pleasant user interface. It's interactive. Folks enjoy, just like they play with a phone. If you're going to play Candy Crush, their point is, why don't you play something that helps, advance biofeedback or helps, reduce your stress. So they cast a wide net, I think, with the intention of including, all of these types of interventions. But, essentially, while they can be used to augment in-person care, all of these can really occur between patient and digital content.
I think some key points that you just mentioned that I'd highlight is anytime there's something that's diagnostic, professing to do some type of treatment or management of a disease, you absolutely want to look into the science behind that, because those are the areas of stepping stones of making sure that the science does back up those claims and that that's part of what you're reviewing as the provider who may be recommending that as well.
Agreed. And, the day may come where we have algorithms in place, Margot, that, are so accurate or so precise that there are fewer errors than human judgment. But that day is not now. So the behavioral health space, we haven't quite gotten there yet, and so we're working.
Excellent point. So it's a good segue actually into this question of something that is kind of not based necessarily on decision science, but it's how do you manage when there are perhaps different recommendations that you're being asked to follow, and how do you juggle a kind of what might be considered a best practice yesterday and a new guideline today. And of course, this is a theme of things we've talked about throughout all of these telehealth chats, in the wake of a COVID-19 pandemic. But we have currently CDC recommendations, and I want to just emphasize the best place to find those is actually on the CDC website, and you do have to do a little digging, but they're not too hard to find. But those recommendations for physical distancing for medical practice kinds of settings are available. The trick is you can't just be looking at the federal or the CDC ones. You also have to look to your state or jurisdiction's Department of Health or Department of Health and Human Services. So I think those are the two main titles that you might look to, but these are the folks within your state and jurisdiction that actually have authority over kind of giving those guidelines in your local area. And that becomes important because sometimes those can be in conflict with each other. And the CDC offers recommendations. Well, your current state is going to have guidelines and laws that may be much more relevant for you to follow. The thing I want to say as a caveat to that, the licensing boards are not the ones that are or have any authority over those health requirements or those health recommendations. And so, you may ask, or your licensing board in psychology in your jurisdiction may have put out some, support resources, but they're not the ones that really have any authority over that. So while you may have some frustration if you've tried to reach out and they don't have anything to tell you, that's probably why. And these things are changing constantly day to day. They're getting a little maybe fewer changes in between things, but as we're moving to this different stage of, dare I say, recovery, or the next side of the pandemic phase, we're going to be seeing some differences there, and those truly are the places to look for those guidelines and recommendations. A couple points to consider here. You may find that information and you may think about it in terms of your own practice and what you may do individually related to patient care. But there's also either an employer level to consider. You may be the employer or you may be the employee in this circumstance. And there's also patient safety to consider. And a couple things that have come down the pike in the past month related to employers, and it kind of has come to be that employers now can actually require staff or employees to be vaccinated. And that has been, there's some litigation out there that has come to pass that you'll want to kind of pay attention to, depending on the employment situation or scenario that you're in. You may not, if you're the employer, be prohibited from asking an employee about whether they're vaccinated or not, or why, or if they plan to. But employers may require a vaccination for employees. So that's not in all jurisdictions, but certainly that's something to just know is out there. I think the other piece of that is, if you're the practice owner and the employer, what are all the things you need to consider in keeping folks safe within your practice in terms of your employees, your staff, your care providers. And that's kind of the first level. And then the next level is there's an integration with patient care. And what does that mean in terms of what you're talking with patients about or making requirements of, in terms of, are you asking patients if they're vaccinated or proof of card? These are not things that I'm recommending. I'm recommending that you think about how these things may interlay and interplay together. And there are some, I think, both individual considerations you may want to think about, as well as kind of your practice as a whole and staff. And if you're employed, and that may be a whole other level that you want to be thinking about of this return to work question. And I know we've got a few things coming in about return to the office setting and not working from home or video conferencing necessarily. But overall, the idea here is safety within that work environment, and then patient safety within that practice environment. And boy, there are just so many different ways and considerations to keep in mind in this realm with the recommendations as well as the increased vaccination adherence and or push for folks to get vaccinated.
These are such important points, I think. And you really highlight, and I know, Margot, you and I have spoken about just the intersectionality of themes that, are protecting the public, protecting our employees' protected health information. We are both allowed, employers are now permitted to require vaccination, and it is a sensitive and controversial topic regarding inquiring about vaccination status. So, I find these things at odds. The general guidance that I seem to perceive is to, try to follow what is promoting the best health of the patient population and the work community. And I think you highlight the manner in which we need to look for local guidance that as to how that CDC guidance is being implemented. And I think a great place to start are our departments of health, our state departments of health, and then if our county offers any health guidance. I think that, if we do this, it gives us very regionally specific guidance, because as we know, some of this varies in accordance to vaccination rates, to occurrence rates in the jurisdictions in which we reside. And so I know exactly, there's a similar thing in my state of Washington where I practice, wherein outpatient mental health and inpatient mental health have separate but specific designations and very specific guidelines on masking, for example. So if I just read the CDC guidance that told me to do one thing, I would say, oh, well, I'm permitted to do this. And if I then went to my state department of health and read the guidance for outpatient mental health, which is the clinic in which I work, I would read something very different, and I think it's in these nuanced applications that we find our sort of marching orders and that concrete information, which is what we need. It's hard to be ephemeral when you're trying to give people rules to follow.
Right. I think the other thing too is you can't just look to your other colleagues because, in some cases, counselors, may not be considered the same as psychologists and may not fall within that medical side. And, or, if you look to, what your eye doctor is doing in their office and you think you're medical, it may be very different in your jurisdiction. So I think as we all were kind of transitioning to video and closing offices, we're all kind of consistent in how to approach that model. And it's going to be a little different as we're coming back into the offices, as they may be considered quite different. I think folks are putting in the chat, well, is it ethical to even ask patients if they're vaccinated, and or can we actually require patients to be vaccinated? These are really amazing questions. I think there are the very questions that all of us have on our mind. I mean, there becomes this consideration of, well, what is your personal safety, health risks, all of those kinds of things to consider. What's your office practice doing? And then next level is, okay, now we're opening the door or considering opening the door for patients. How are we going to approach that? And with patients, we're used to managing and dealing with protected health information because that's what we create when we're working with patients. And that's a little bit different. That I think in that realm, you can potentially consider asking as part of, how you might ask about other medical circumstances with patients. However, that's one thing I do want to mention in terms of your staff and employees. If you're asking about vaccinations, you do need to think about that as protected health information, and who and how and what permissions you have in sharing that with others, including patients who may be coming into your office setting. And so how do you want to navigate those conversations? And from our standpoint, we're here to talk about kind of the ethical consideration and the practical implementation of all of that. There's so much to tease apart in those ethics of, is this even a question to ask patients? And what do you do with the information you get?
Well,
aside from the storage aspect, do you believe it? A patient you've been seeing for 6 months, maybe you do, maybe you know them well. A new patient coming in, do you trust that? We're supposed to, but can we? I mean, these are some really big health concerns that we're talking about.
Margot, I'm putting an article in our chat box if
Oh,
the viewers want to take a look at. And this is something that I read that I thought was really interesting that talks about this big question, and I think as they said in this article, it is a largely legally untested area requiring vaccination of our patients. And so I think they would opine that, we take vaccination status into account along with other health risk factors, that vaccines aren't 100% effective. So irrespective of vaccination status, we always practice, good hygiene, good distance, et cetera. But I thought was interesting. And I think it really highlights the manner in which we don't yet know, we don't yet know what the fast and firm rules are. But I do think that anecdotally, many people are electing to shift more of their practice to telehealth as one way to mitigate some of this risk. I mean, I will share with you, I'm somebody who's high risk. I have been, I'm vaccinated now, but not everyone in my family can be yet, and so for my practice, I'm still pretty much on telehealth. And that's a choice I'm making for my own health and wellness, that I think in some ways, am I chickening out the vaccination status question? Maybe I am. But I think that, each of us are going to have to determine where our risk tolerance is. And then in the coming months, monitor and understand what sort of legally is advised and even permitted. I'm looking at the time. We've seen a lot of great questions.
we have.
I'm wondering, should we select a few and talk about them?
Absolutely. And I think some actually kind of go along with some of the things that we have been chatting about as well. But do you see any that jump out for you?
I do. I see a couple. One, I think it's just a quick one to be answered, but a really important one, which is what kind of informed consent may be necessary in reopening in-person therapy? And thank you. This is a great question. I would recommend that you go to the Trust website where they have a template for return to in-person therapy. And it really offers a nice, overview of those components that talk about benchmarking expectations for monitoring our own health, for, monitoring our temperature, practicing social distance, whether or not we're using masks, making sure that all of these factors have been discussed in advance, because you don't want someone showing up and saying, oh, actually, I have a little bit of fever today. Am I supposed to wear a mask? This is a conversation we want to have beforehand. So I'm going to find it and I'll put it in the chat box. But I would go to that document library and take a look, because I think the Trust has done a very nice job, and it's free. You can download it and adapt it into your own documentation.
I would just add on to that this is a time frame to really reconsider. We've talked about this, once or twice a year, you should be looking through all of your informed consent documentation anyways to make sure it's still relevant to the nuances of the things that you're now doing. And maybe you've added something new in and that needs to be included and didn't quite get caught or added in before. But this is a time also to really allow that informed consent document to cover a lot of areas. So, initially we all kind of only had in-office practice documents, and then we went to only online practice. And so your informed consent now may actually consider and contemplate some of both of those ways of practice and or how to make decisions or determinations about that. So just to kind of add on to that, Sarah.
I see another good one. This is, I think this is kind of interesting. What do your practices look like on a typical day? Are they in person? Are they video conferencing? Are they both? I will give short shrift to this, but I think it's a good question for us all to be asking, what do we want our practice to look like? And I think the last 18 months, or I don't know what month it is, the last 15 months have democratized telehealth in a way that I just never would have anticipated at this point in time. I'll share that I am almost exclusively telehealth. I have one case I see in person in the care of someone experiencing domestic violence, and I think that is relevant. And so there is a And I should say, even that is mostly telehealth, but there have been opportunities otherwise. So I think that it is a personal choice as to whether or not we want to, whether or not, how we're going to think about telehealth moving in our circles moving forward, and what telehealth component will play moving forward in each of our practices. So I'm pretty much exclusively telehealth. In fact, moving forward for the next 3 months, I'm scheduled all telehealth. So how about you, Margot?
Well, I will say I am pretty exclusively telehealth to the patients that I'm following with. From time to time, I have met one of those patients outside in our kind of backyard picnic area at our office at their request. And I have to say, I really like outside. And I think that's kind of one of the things that I will be looking to, as we are coming back into in-person, in real life care is, are there ways to incorporate walking therapies or some things that we've gotten really creative with through the pandemic, and still considering confidentiality and all those other aspects. But I think we have the opportunity to have a little bit more flexibility. So I put a plug in for some outside fresh air. I will also say I'm in a practice setting where I have colleagues that one particularly is I would say 80% is assessment practice. And so her practice has become back in the office, and there's cleansing and there's time between patients. And when patients are here, we've been masked. And so it's not just what am I doing, but we've got this kind of rhythm of who all's in the office, when are they in the office. We only have one space that is 10 feet apart, which was our chosen requirements initially. And so we've really had to modify a lot of things, and the rest of services are majority online. So we've had a few consults where we're actually going out to provide the service on site where clients are, and that's following the social distance, physical distancing requirements, and or other COVID-19 requirements in that setting. And that's provider by provider who's comfortable doing that. So I think an excellent question. And that kind of covers off or segues to another question that came in, Sarah, about having a suite in a professional building where the psychologist is subletting to 2 other psychologists. So they're not employees, but they're contributing rent, I guess, into that practice office. And some have returned to the office with patients, some haven't, and about liability coverage for such a scenario. And I think we're really getting to a question that it has, part of that legal hasn't been tested of, is there a liability that we carry? Historically, if somebody got the flu after they've been in our office, probably wouldn't be a big deal. Probably wouldn't, it's very difficult to determine where exactly does that come from and how is that transmitted, but we're dealing, we're living in much deeper times with that now. And I think a really great question for our risk management colleagues, but you may have an idea on that too as well.
I have to admit, this one stumps me a bit. I mean, this would be where I would want to well understand the nature of the relationship. I think in this circumstance, there is no professional relationship beyond the sharing of space. That being said, if I am the person who holds the primary lease, if I am the person who pays for insurance, for professional office insurance is not the correct name for that policy, but that would be, I would want to well understand, in some ways it is not different from someone coming in and saying, I caught the flu, or I caught, something else, secondary to practices that I thought were substandard in some way. I can tell you that I, at one point, did inquire a little bit about this, and the feedback I received at that time was, this is very hard to substantiate. It is very challenging for someone to say, I got COVID from you in your office, and I know it's because I touched this doorknob and then I licked my fingers vigorously or whatever. I think it is very, very challenging beyond the practices of contact tracing, which are articulated often through health agencies. And so, I could imagine a circumstance in which health tracing suggests someone who is in an office environment and so forth. And I think that's the most likely circumstance in which you could actually substantiate, where your contact came from. But even then, I think it's very challenging. So I think this is a good example, Margot, something we need to go do our homework on and come back next time and have a good answer.
Well, and speaking of time, we still have a couple areas that we wanted to talk about. I think we're going to have to shorten those a little bit so we can make sure we get through those topics and a few more questions before we get too close to the top of the hour. So I am going to toss it over to you to share really quickly about some of the concepts you were thinking about with couples therapy, and then you can toss it back to me for some insurance items.
Well, as you and I were speaking about, Margot, the opportunity to deliver care to couples and the just tremendous increase in access to telehealth, have aligned nicely. That we know from some of the research in Medicare benefits that telehealth is reaching here to sort of underserved, significantly underserved populations. And I think, one of these areas are those of couples. I think there are tremendous challenges that people overcome, inclusive of scheduling challenges, childcare, transportation, even if we're just talking about collateral report opportunities, much less, family therapy and couples therapy. So I think that this has been a tremendous growth area. It's an area of practice that maybe we hadn't considered for telehealth prior to pandemic. I think that it really asks some questions about how important it is to have two people in the same room. I know when I do couples therapy, I really like them to be in the same room together because I want to see how they interact with one another. It's hard to see, someone's rolling their eyes on a Zoom call with someone's comment. It's a little harder to see. I think you get a little bit more richness when they're sitting right next to each other. Now, I think there's also a challenge associated with that because you have less richness in terms of being close, in terms of seeing facial expression and sort of the minutia of movement. Now, when I'm talking about some of these themes, I'm making an assumption of lower conflict couples therapy. And I think that, in those circumstances, we have the opportunity to overcome access challenges. We have the opportunity to see a home environment, capture more richness. But I think that we need to be really thoughtful about those high conflict therapy cases for couples and families and the liability associated with managing that. As we know, there are no strict prohibitions. No one's saying don't do that. But I think that we always need to go in with our eyes wide open, thinking about, okay, well, how would I manage this type of emergency? I want to acknowledge that when things have become very heated in my office, I have yet to throw anyone to the ground, really physically intervened, but I do think there's something about the physical presence that I'm there that creates a different dynamic, certainly. And so, particularly if you work with high conflict couples, families, being really thoughtful about safety planning, being really thoughtful about how you will de-escalate, particularly if people are in the same location, is worthy of consideration. I know we are short on time, so I could vigorously opine forever, but I think that, just really thinking through, do we want folks in the same room? How do we think about their safety? And how do we make sure that we're planning ahead for every circumstance that we can think of?
Well, in that kind of segues to the theme of what I was going to talk about with insurance coverage. And, even as we're checking in this week prior to our chat tonight, we know there's some contemplation out there in the Medicare, Medicaid world of maybe rolling back some of those considerations of what was put in place with the pandemic of reimbursement for telehealth. And, we haven't seen movement in that yet, but we are seeing some movements as different states are kind of rolling back. The governor executive orders are changing regarding some of what the other healthcare coverages are now thinking they're going to do or have been doing. We've seen some changes in some of those larger insurance carriers. And there's no single answer for this other than it is something you're going to have to spend some business administration time on in your practice of calling and keeping up with and reviewing emails that may or may not be coming out from the insurance carriers as to any pending changes or changes of kind of where you can bill from and or some of the codes that you should be using. It's not easy to spend a lot of time doing that and doing care. Patients don't understand a lot of those questions to ask, and helping them navigate what they may need to know to make a determination if you're going to stay as a telehealth relationship and the insurance isn't going to cover as much or all of that. What you're going to need to have preparation for those conversations of how that is going to transpire with patients that it may impact. It may not impact a lot. It depends on the carriers. I anticipate we may see a lot more providers transitioning to more of a cash-based practice and not being involved with some of the main insurance carriers and or Medicare, Medicaid, just because it's much easier to do that. But that does change the flow of who's coming in and access and all of those kinds of things. And I think the other thing, Sarah, when you and I talked that you had mentioned was just making sure we're in tune with the service codes. And I noticed a question that came in as we've been chatting related to, if you're still providing telehealth from your home office, what is the service code that you should, or the place of service code that you should be utilizing there? So I think you had mentioned, Sarah, that really, we only switched from the O2 telehealth service code because a lot of companies couldn't keep up with changing what they needed to in their software. And so they had just recommended using the place of service 11 because it was being paid out at that same rate.
Yes.
But we really should be using the O2 unless you hear something different from the insurance carrier.
Absolutely. There were a limited number of circumstances in which providers received guidance to, instead of using O2, and O2 is the correct one, let's say that 3 times, O2 is the right one. There was a limited set of circumstances in which insurers said, hey, there is now a legal mandate for us to reimburse at the same rate as the in-office care, which would typically have the place of service code 11. And they said, boy, we can't keep up with this. So please use place of service code 11, which is technically incorrect, but they asked us to do it. And in some circumstances, that's what providers did. I'll note that in the last month, I have seen a few, I believe in Alaska, some of the Blue Cross Blue Shield companies, and elsewhere, specific jurisdictions, specific insurers. So it's hard to make a global statement, but there have been some insurers rolling that back and saying, go back to use O2. So I think for me, a safe bet is always O2 for place of service code. Yes, it can be from a home office. That is now understanding that when you do that, you're often then putting that home address on the CMS 1500 form. And there's not a great solution to that because that is technically accurate. They don't like PO boxes on those forms typically, as we learned in prior telehealth community chats. Mm-hmm. So I think it is, it's a worthy question that O2 is probably the right answer. The downside is sometimes 11 is reimbursed slightly higher. And so, it's never pleasant to forego that extra reimbursement.
Mm-hmm. And I guess, do we anticipate changes? Well, in terms of insurance coverage, I think it's a fair bet, safe bet to say you can always anticipate that there will be changes in insurance coverage. Yeah. I think we're seeing some literature that's really suggesting a lot more use and access to care in terms of mental health care, and therefore we may be seeing some improved health and improved long-term stability for these patients that overall may be reducing the cost of health care. And we're going to have to wait and see a little bit in terms of what some of those studies are saying long-term, but that does give some suggestion that perhaps this is a way of really helping others access care. Now, the question will be, will it maybe maintain at that same reimbursement rate? And who knows, because that's a whole other telehealth community chat to cover those topics. But I think it's always safe to think there probably will be changes, and it's always a good practice to have somebody at your insurance companies for whichever panels you're on to really connect with on a fairly regular basis, maybe quarterly or so, to really have some conversations about that. So, Sarah, is there any other burning question that you see before we transition to a couple updates for folks?
I saw just one that I really thought was a good one to mention, and two things. One, I've seen a lot of really great questions about vaccination status, our right to inquire, our obligation. And I think this is an area in development. I know this is going to be my homework area for the next few months, because I think we're going to learn so much more in these next few months. Our professional organizations are opining, our attorneys are starting to opine. I say "our" as the general matter of attorneys, not my personal attorney. And I think as you mentioned, Margot, I believe in May of this year, it was the Governmental Office of Accountability, it's told Congress, who is under tremendous pressure to make permanent some of those Medicare allowances for telehealth. They said, well, wait, we need to understand the health outcomes. We need to understand, what is going to happen moving forward, which made people take a sharp breath in, because we didn't know what that was going to mean for Medicare. To my knowledge, there's not been huge changes as of yet, but we're all sort of watching. And this is the period that it's happening. So the only other thing I would want to be sure to touch on, and then I'll ask you the same question, Margot, was we had someone ask about an omnibus resource for telemental health laws. Where can I go to stay up to date on telemental health laws? And I wanted to mention, as always, we like to mention the ASPPB overview of interjurisdictional practice laws that have emerged during the pandemic. It is a really great up-to-date resource. They do a really nice job. This fundamentally talks about interjurisdictional practice. One that we have talked about less, and I believe I can put this in the chat, is it's, I believe, a law firm, Epstein, Becker, and Green. Now, I want to acknowledge this isn't something that is maintained by professional organizations. This is a law firm. I don't have any relationship with them, but they have made a very nice app that has all 50 states and telemental health laws. I think they do a nice job, and I think it's worth taking a look at if folks would like to, and it's free. You can take a look, see what you think of it.
Fantastic. I can already anticipate a lot of people pulling that out and getting that access. I think the other one I would mention, we have on our resource, and that's from the governor's site, where there's a lot of executive orders that have been listed and in different phases. And so that's always another good one to connect with. But as always, ASPPB, which is the organization that connects all of our licensing boards together, and who's helping roll out the SIPAC, really has done a fantastic job of helping connect us with that information. And maybe, Sarah, I'm going to just jump in because my update is super fast, and then we'll go over to yours. And mine is just that interjurisdictional update of reminding everybody about Florida. Florida has the governor executive orders have repealed, and as always, even prior to the pandemic, Florida has been very insistent that if you're practicing telehealth, you must be in Florida and licensed by Florida. And if your patient is in Florida and you are not, and not licensed by Florida, you may not do telepractice to Florida. And I know we get a lot of questions about, I'm in this jurisdiction and my patient's going on vacation, or I'm going on vacation and my patient's staying home, and can I telepractice? This is one example where Florida's always been clear. If you're serving anybody with psychology in Florida, you must be licensed there. And this kind of brings up some really important points of that interjurisdictional question of knowing where your patients are, even if they, are video conferencing in and you think they live in the jurisdiction you live in. You do need to have them check in with you on that and state their location. So beware of Florida or be observant. And Sarah, I know you have some really cool new resources coming out to tell us a little bit about. So maybe we can chat over to that.
We'll be conscientious in Florida.
Yes.
Yes, we have received a question that was incredibly timely, actually, last time about certification. And the question was, should I pursue telehealth certification? There are various entities that offer it, and how should I think about that? And, it's one of these areas I think is really relevant to think about, particularly if you are interested in increasing your own competencies, if it's an area that you think you could stand additional training. It is not required, and I like to mention that it's not something to practice telepsychology. You don't have to have any sort of specific credential or certification. However, I think it is a really nice proxy for ensuring that we are obtaining benchmark competencies. It is, I think, a good analog to making sure that we know in our ethics code, we are required to make sure we have the necessary competencies to deliver a service. And many of us didn't have this available when we went to grad school. We didn't talk about telepsychology so much when I was getting my PhD. So I think this is an opportunity for us to continue our education in a thoughtful, meaningful, structured way. So I am a fan. If you participate in SciPact, you are required to have 3 hours of telehealth CE. You can use the telehealth community chats for that, by the by. And this is kind of a neat opportunity to announce something, and that is that the Trust and the National Register, I believe in the late summer, early fall, will be offering a telepsychology competency credential program. I've had the great pleasure of working with Dr. Martin and Dr. Morgan Salmons at National Register and their thoughtful leadership, into creating a program that helps our members to gain the necessary benchmark competencies to confidently, ethically, safely deliver telepsychology services. So as a general matter, I think they're good. I think they're a nice proxy for what could be a vigorous course of self-study as well. But, I tend to be a fan.
Fantastic. I am excited to see what is coming about. And, I know a lot of folks that they're asking about the SciPact. There's a lot of new laws coming, joining into different jurisdictions into the SciPact. We kind of see that a couple times a year. January and July tend to be some months where new laws come to be. So that's why we've seen an increase currently. We had one question I accidentally dismissed. I didn't mean to do that. I didn't mean to answer it live. I was going to type an answer, but I clicked the wrong button, and somebody was asking, does the patient and the therapist both have to be in Florida? And we've had a few people comment about Florida. This is new information out of Florida as of last week. I would encourage everybody to go and look at if this jurisdiction is of interest to you, of course, but check it out from the raw resource at the Florida Department of Health or Psychology Board in Florida, and you'll get that information direct to meet your needs. So I think, we want to just make you aware of some of those key things. And as this relates to the SciPact, I think there are requirements there for 3 hours of telehealth specific training. I'm pretty sure it's 3 hours. Mm-hmm. Yes. So I love the fact that this new option is available for folks, and I'm really excited to see that coming about. So I am taking a final review. Somebody asked what's SciPact. I will answer that really quick. And we'll take a final review through the chat questions. The SciPact is a compact. It's kind of similar to how driver's licenses work, where a jurisdiction can opt in based on the laws that they pass at their legislative level to participate in compact with other states that would allow a licensee from one of those states to provide telehealth services and or limited in-person services to residents and citizens within the other jurisdiction. And so then there's kind of reciprocated allowances back and forth within that compact. So that's what the SIPAC is. You can check that out through the asppp.net.org website. That link is on our resources that we've sent out previously as well. And that'll actually loop you over to the SIPAC website.